We're going to finish things up with some critical care pearls. And Sarah Dubbs is doing fifth hour conference today, and she's okayed us to run into that time a little bit. So we're not going to worry about finishing right at 11:30. Our two speakers for this section are David Gordon, and Yoshi is going to be back to add on a little bit. So for those people, the grads that don't know David Gordon, he finished our EM program in 2018, then went up to New York to do a resuscitation fellowship for 1 year, and then this past year has come back to university to do a more formal critical care fellowship. And he's been doing quite a bit of time up in the ICUs working with these patients also. So he's going to give us some critical care pearls for the emergency department, and Yoshi will join him and add on a little bit at the end. So David, are you, there you are. Okay, go ahead, take it on, take it away.
Hey guys, I'm David Gordon. Thanks for that awesome introduction, Amal. It's really cool to talk to everyone and to see and talk to and hear from some of my old classmates, and to hear from some of the people who were like my seniors who are now continuing to educate me. So one of the things in this entire setting that I have developed a real interest in is this idea of awake proning. And one day, I hope, I think, COVID will not be something that we have to dedicate our entire beings to learn about it and treat. But I think we're going to take a lot of lessons away from this time about how we treat and manage our critically ill patients. And I think awake proning is one of the things that I hope we don't stop when COVID is done or gone or less prevalent, and that we apply to our patients moving forward. So I want to talk first a little bit about the physiology, and then about some of the data that's come out recently regarding awake proning and COVID, and then we'll circle back to awake proning and ARDS in general, where it's already been pretty extensively studied. So we all know about proning in ARDS. And, this came out after the PROSEVA trial. There were a whole bunch of trials about proning in ARDS, and they were not especially positive. But as we got better at proning, as we got better at our patient selection, we found that proning really worked. And one of the reasons that people were persistent is because the physiology of it makes sense. And as is so often the case in critical care and emergency medicine, which is one of the reasons that I absolutely love it, we have to consider and think about the physiology, and sometimes that's all we have to guide us. So basically what's happening is, in general, the most compliant part of our chest is our ventral chest wall, right? So that moves the most easily. And our chest is somewhat shaped like a box. And our lungs are somewhat shaped like they have to expand to fit inside of that box. And so our ventral lungs will expand more to fit our ventral chest. And our dorsal lungs, as we've all seen, especially in these COVID patients, and we saw with the ultrasound lecture as well, so often they have dense consolidations posteriorly, is that those areas are expanded less, they're less recruited, and so they're more collapsed. And what happens when you prone someone is all of a sudden the most compliant part of the chest goes from being that ventral chest to being the dorsal chest. And even though you're still shaped like a pyramid, it's just now upside down, your dorsal lungs also have to start expanding more. And so you end up recruiting those lungs. And to go along with that, because we live in the world and there's gravity, our blood flow is adjusted based on our height of the chest. And so if we have a whole bunch of dorsal lung that's collapsed, that's where we're going to get most of our blood flow, unfortunately, because of gravity. And so you have some VQ mismatch. When you flip people over, you have less of that because now those dorsal lungs are recruited. And when you prone someone and you put them on some sort of positive pressure, like high flow nasal cannula or non-invasive, what ends up happening is you get a more even distribution of that recruitment from those maneuvers than you do from just putting them on those things alone. So for instance, high flow may increase your lung recruitment in and of itself more in the supine position. But when you flip someone over, that's almost, and when you do that, it's almost entirely in the ventral lungs, you get that benefit. But when you flip them over, you get it almost uniform across the ventral and dorsal lungs. And therefore, you're going to have less VQ mismatch and therefore better oxygenation. All of us have probably been following a lot of the foam and a lot of the reports that have been coming out of New York and Italy, and probably speaking to our friends there. And we already heard today, from people like Nick that they've been doing awake proning, and I know we've been doing it here. There have been a couple papers that have come out specifically in the setting of COVID for the efficacy of awake proning. So there was a case report that came out recently of one patient who was awake proned on and off for several days. And he was on high flow nasal cannula, and every time he was prone, his sats went up. Then he would supinate and his sats would come down. And he did this for several days and completely avoided an intubation, which we've talked about is probably a good thing in these COVID patients, that after you intubate them, they probably do worse. There was a larger case series of patients that came out of New York where they didn't do the typical proning as we describe in ARDS, where we prone someone, as one of my co-residents said earlier, tummy time, and then supinate them. They did more of a rotisserie style proning, where they spend some time on the right, they spend some time on their chest, they spend some time on the left, then they do some Trendelenburg. Some people have called that the pig roast. I think we could just call it the patient roast, and that might be a more appetizing name to everyone. And they had really good success in terms of seeing an improvement in oxygenation. So people came in at about 80% sats, they improved to 84% sats with oxygen, and then they came up into the 90s when they got proned. Overall, this cohort of 50 patients, a total of 18 got intubated. 13 were in the first day. A number were within an hour or so of getting proned, or not too long after getting proned. And about 5 were after the first day. But I think that's pretty good, given the number of people that we're dealing with. If we can help avoid any number of them, avoid intubation. It's been formally described in some of the protocols coming out of China, specifically one of them, where they risk stratified patients to being either low risk or high risk. And then if they met certain vital sign abnormalities, like a respiratory rate greater than 30 on room air, tachycardia in the 120s, SATs less than 93%, they were escalated to critical care. And once in critical care, they had limited fluid resuscitation, either high flow or non-invasive, and awake proning. And compared to everyone else, they had an intubation rate of less than 1%. And a mortality rate of versus over 4% in their comparative region. So I think that all this stuff lends some credence to awake proning specifically in COVID to avoid intubation. But awake proning goes beyond COVID, and this is not some concept that we developed just in the setting of COVID where we said, let's flip them over. This is being reported pretty extensively in the literature going back several years. So there's a number of case reports where we have awake proning in a variety of different lung pathologies, and all these patients have better secretion clearance, they all have better oxygenation, and it helps many of them avoid intubation. There's a larger case series of about 15 patients, and they were all on a variety of different oxygen support, nasal cannula, high flow nasal cannula, non-rebreathers, non-invasive, helmet CPAP, and they all had improvements in their oxygenation when they proned. And they would probably, those benefits, while they existed while they were proned, as we've seen pretty often, both in COVID and not in COVID, they go away when we take away tummy time. So the kind of most rigorous study of this is an interesting study that came out, I want to say late last year, by Ding et al. And essentially they took patients who were on non-invasive, and their goal was to maintain their sats, I want to say above 90%. and then they had an algorithm for how they escalated their care from going from high flow nasal cannula to high flow nasal cannula with proning to non-invasive with proning. And when they put people on high flow nasal cannula and escalated them, if they needed it, escalated them from high flow nasal cannula to high flow nasal cannula with proning, the patients that benefited, that overall ended up avoiding intubation, had benefits at each one of those progressive steps, versus the patients that did not benefit did not have benefits at those different escalations, which tells us we can tell pretty quickly whether or not someone's going to benefit from this at least by those standards. In this study, they had a cohort of 20 patients. They had a predicted intubation rate based on the severity of their ARDS at about 75%. And that overall in their study, about 45% of their patients got intubated. So they avoided a fair number of intubations simply by instituting this awake proning. We think they avoided a fair number of intubations, right? It's not the most rigorous study methodology. Based on and because they did awake proning for their patients. So there are some questions about how we can do this and what's the safest way to do it. Across the literature, patients tend to tolerate it really, really well. Those that don't can get some light sedation to help them tolerate it, and they should probably be observed for at least some period of time pretty closely to make sure that they don't get worse. The amount of time is also something that's kind of been discussed. What's been in the literature for the non-COVID patients has been about 2 hours, 2 to 4 hours, about 2 to 4 times a day. Seems to be the patients that either benefit from proning or the ones that will tolerate it the most. But in the COVID literature, again, there's been a much more they've described this kind of patient roast a lot more. I know everyone just says, oh, well, I prone myself every night when I sleep. And a lot of it, I think, may have to do with just letting our patients be in a position that they find comfortable for them. And then every couple hours asking them to reposition themselves instead of just having them stay on their back for a couple hours or, all day, every day for everything. I think both approaches are really valid. Both clearly have some evidence behind them. The patient roast is, like I said, what's been described in COVID. But I think, like I said, one day we won't have to do, not everyone that has respiratory distress will have COVID. And we're going to have to figure out how to practice medicine in that time again. And I hope that this is something that we can take forward out of this catastrophe that's happened, and we can apply to our patients to also keep avoiding intubation in the future. And with that, I'll take any questions.
Well, great. Actually, how about Yoshi, do you want to chime in, and then maybe we can...
I think the two challenges we face at Stanford initially for the ICU is that there's a fear for self-extubation for these patients intubated with ED or in ICU because you have to put the PPE, and then it's going to be challenging to intubate in an emergency situation like that. So because of that, there are a couple consequences to that. One is that patients are heavily sedated, and at the beginning there's actually no humidification given through the circuit because of the concern for potential accidental breakage to the circuit. So patients end up with having a lot of downstream effects. The secretion became issues later on, so we had to actually put back on the humidifications so that the cilia can work. And then also because the stations, it took a while for them to be able to get extubated when they're ready to be extubated from sedation's point of view, because they're on high dose Dilaudid drips and Versed drips, and they had so much deliriums, and they didn't have those great cough and gag while they were deeply sedated, so they had VAP. So there are a lot of lessons learned. That's one thing I wanted to bring it up. So in other words, like things that we used to do for evidence-based medicine with the ARDS, we didn't really do, partly because of the fear. At that time, we didn't know much about this disease. So the deviation from the standard of care because of the fear for COVID, what it can do, the infection spread risk and so forth, actually, I think did more harm to the patients. And that might be playing some roles in terms of why some of these patients are doing worse after they intubated. Not so much the intubation itself, but things that we don't do for them might be actually affecting. That's one thing I wanted to say. The second thing I wanted to point out is that I think the care has changed, not just for the COVID patients in ICU, but the ones who are not having COVID because of the change in the policy. So for example, we don't allow the visitors to come to the hospital, even if they're in the ICU, even if they don't have COVID, because of what's going on in the state of California right now. So we had a patient's family discussion that we had to do who don't have COVID, and we had to tell them, I'm sorry, but the patient should be converted to comfort care. And the family has to make a decision remotely without being able to touch their patients, and then decide to withdraw care for some of the patients. So I just wanted to share. And the reason why it's important for the ED audience is that when you do end up with intubating the patients in the ED, whether it's COVID or COVID negative, I mean, the PUIs or COVID positive negative, there's a possibility that that's the last time the patients get to talk to the family, and our family has to make a decision later on without being able to talk to family patients about it. So before you do that, you need to make sure you let the patient talk to their loved one, because of potential restrictions of visit policy and so forth. That's all.
That's a really great reminder. Any questions from the group for Yoshi or David, or any other comments from some of our other critical care folks, Cami, Mike Winters, and so on? We do have one
Adria,
question.
do you want to say your question?
Go ahead.
Yeah,
Adria Lee got a question.
So I work outside of Boston in the community, and we've had a lot of issues. Well, not issues, but there's been a lot of debate about how to manage the patients in my hospital, especially because we have to think about transferring patients. Our hospital is like basically they're really trying not to intubate anybody if they can help it, and so meaning that they're using a lot of non-invasive like BiPAP, CPAP, and high flow up in the ICU, and then trying to balance that with, my sense is that in the Boston centers, it's that they're trying to be a lot more, I think they're avoiding non-invasive if they can and intubating a lot earlier. I've heard a lot about this on the internet and like on foam and stuff like that. What are other people doing in terms of balancing those things? And just personally, my main concern is like with non-invasive, the aerosolization risk, as well as the self-induced lung injury that you can get with like the high driving pressures and big tidal volumes in people that are spontaneously breathing.
So I can tell you at Maryland, we are going primarily to high flow nasal cannula first. And when these patients come up, I haven't been, as a consequence of my fellowship this year, I haven't been down in the emergency department this year. So I can't speak exactly to what's happening down there, but I can tell you from the ICU standpoint, we are intubating patients that are in respiratory distress. We have tools we can use to keep them from getting into respiratory distress. So we had a patient on 40 liters per minute of high flow, 100% FiO2, occasionally requiring a non-rebreather in our IMC, who on top of that was a prisoner and was self-proning. And we let him ride that out for several days. Last I heard, he wasn't intubated, but I haven't been back upstairs in a few days. But for several days, we let him do that. That is with the caveats that are where that patient was, where all of our COVID patients are at this point upstairs. They're in COVID wards. So we basically have whole, blocks of our hospital that are now shut off, except for only COVID patients. So the aerosolization risk exists, but only in that area. And hopefully the fact that it's a ward is somewhat protective from everybody else, and everyone who goes back there has on lots of PPE. I will add that there's a great series of papers that I alluded to before, using this like different smoke laser model, looking at the aerosolization risk. And non-invasive, if the mask fits, the risk, and you use a viral filter, the risk is really, really, really minimal, as long as you don't have a mask leak. And even if you do have a mask leak, the size of that cloud, about 30 centimeters above the patient, is still not huge, where you're getting to that 10% mixture of what they're exhaling. But I think the real key is getting a mask. But again, I think everywhere it seems like is trying to avoid. Everywhere I have seen is trying to avoid intubation as much as they can, and leaning on more advanced oxygen delivery tools.
Ben, can you verbalize your comments?
Oh, I don't know. Yeah, you want me to come over there?
No, they can hear you.
Oh, okay. Yeah, hey, everybody. I was just saying we've had, and kudos to Gordo and others for synthesizing the evidence because there's such a lot out there. With Express Care, we followed sort of the trend, and we have transported literally up to about 50 patients that are requiring these devices. We've had really good results with non-invasive ventilation. We have not had any providers come back with any type of conversion. That being said, I think the issue is you have to not only pay attention to strict risk-benefit synthesis, but also strict attention to PPE. So as Gordo said, if there's a benefit to transport, and namely connect people to definitive care, avoid intubation, I think we can transport these patients and minimize the risk. And the reason why I mention that is because the transport environment is a lot more confined. I mean, it's very restrictive. There's not a lot of negative pressure. But in our conversations with the infection preventionalists, putting a mask over high flow, considering decreasing the flow rate, or actually even using CPAP with a viral filter, I think we've had really good results with. So I can't say it's been supported by very rigorous evidence, but we've had very good experience in that regard.
And the mask over the high flow is something that has been looked at in that same model. It was looked at in the Vapotherm stuff that they published about, using Vapotherm with the mask, and they found it was pretty effective in terms of reducing overall spread, or at least spread in the ventral direction. But there's more spread to the sides. But overall, yeah, I think if you put a mask on them, you use really good PPE, I think it's fairly safe.
I think we can take one last question. Mac, do you want to unmute and let us know your question?
Thanks. Gordo and company, thank you so much for your contributions. I have a specific question about transporting patients who are intubated, both in the emergency department, but also potentially for hyperbaric transfer from the floors. Say someone is COVID positive, they need to come down to hyperbarics, or we just intubated them in the emergency department, we want to take them upstairs. Right now, they need to be bagged during transport. And so the big concern is when you disconnect the bag, that's one of the aerosol sort of risk opportunities. My question, and I've posed this question to our respiratory tech and safety officers and stuff like that, and they just say that it's not protocol. But my question is, why can't we just attach the viral filter to the very tip of the ET tube and transport, and then that way, whenever you disconnect or reconnect the bag or into the circuit, you already have a filter in line. Is there such a respiratory flow with that filter directly there that it's a problem, or why are we not doing it that way?
My suspicion, so at university, our filters are connected at the end of the expiratory limb of the vent. So vents have two limbs, at least ours do, right? So you have an inspiratory limb that air comes in, that comes to the tube, and then there's an expiratory limb that air goes out, and that's just a function of the mechanics of the ventilator. Our filters are at the end of our expiratory limb where they plug into the vent. My suspicion is that they are somewhat by convention, because I think we've always had these filters there. But another thing is that it blocks, it is a risk for taking up a lot of moisture, and so you lose the efficacy if it becomes moist.
I think another problem is that it impedes your therapeutic mechanisms. So you can't have the inline suction in place. And so if you imagine that a lot of these patients, not all of them, but some of them are having secretions or whatever issue, it makes less sense to do that if you're going to have to change out the inline suction. Also, in terms of if they're going to need bronchodilators or anything like that, having that filter there is really, it just doesn't make a lot of sense. And that's just some of the more practical parts as well.
Great.
But it is definitely an issue in that in transport. I mean, I've definitely seen people become disconnected from the vent at various points along the vent circuit.
All right. All right. Thanks, David and Yoshi. And with that, I think we'll wrap things up. First of all, I just want to thank Michael Bond for his work with putting all of this together in terms of managing the Zoom and keeping the chat and everything else going. I really, really want to thank all of the speakers for their time. I know people have logged in from all over the country. Yoshi, you need to get to sleep as soon as we're done with this, waking up this early. And it's, you know, part of the fun for all of us is just being able to see so many people. It's kind of like a little reunion that COVID has brought for us. During one of the breaks, I just scanned through all the people that were logged in, and amongst, first of all, I have to do a shout out to Wade because I haven't seen him in forever. So Wade, thanks for joining. But just in terms of the people who weren't speakers and not currently in any of our institutions, I saw graduates including, let me see, Colleen Gibson, Liza Thomas, Adria Lee, Dre Moladu, Eric Shaw, J.B. Nabel, Heather Masadra, Shannon Petukov, Kelly Ellis, Brandy Knight, Nicole Amato, Christina Bennett, Jeff Dingman, Mifong Mitarai, and Ann Walker. I'm sure I missed a couple of others out there. And so thank you all so much for joining. We should do this more often, and it shouldn't take a global pandemic to do it. And on behalf of the faculty, I just want to say how proud we all are of all the hard work and contributions to medicine and healthcare you all are making. And if you guys ever want to rejoin our conference, we're doing these Zooms every Wednesday. And I think, Michael, they're pretty much open to whoever wants to join, and it would be great to get some of our alums. Would you agree? Are they pretty open like that?
I completely agree. The link that got sent out for this one is the same one that we'll always use. So please join anytime you have a chance.
Yeah, and if you guys have any questions, just send me an email, or you have my my phone number also if you want to text. And I hope to see you guys again really soon. So thank you all very much. It was really, really a lot of fun. For those people, for the